Good evening, all of you. Thank you, organizing team, for giving me this opportunity. So today I'll be discussing regarding mechanism of resistance to immunotherapy. So basically, this topic is very important for our residents during their theory examination. So we all know how immunotherapy works. They inhibit the binding of PD-L1, PD-1, and binding of CTLA4 to B7 and activate T cells, and they cause tumor killing. So what are different classifications of this resistance to immunotherapy that can be classified into primary resistance or acquired resistance? Primary, that means patient is not having any initial response from the baseline. Acquired means initially patient responded with immunotherapy. Later, after 6 months, patient progressed on treatment. Further classified into intrinsic or extrinsic resistance. Intrinsic means tumor related resistance. That means tumor is itself resistant to immunotherapy. Extrinsic means the factors that is present in tumor microenvironment and tumor immunity cycles that are responsible for resistance to immunotherapy. And other can be immune inflamed, immune desert, and immune excluded. Immune inflamed, as the name suggests, that immunity is there, immune cells are there. Despite that, tumor is inhibiting immune activities. Immune desert, immunity that immune cells are not present in the tumor microenvironment. And immune excluded, that tumor prevents the immune cell infiltration in that tumor microenvironment, and that's why that is causing resistance to immunotherapy. So immune response is a continuous and dynamic process, and there are multiple interactions involving immunologic, genomic, and host characteristics for this immune response. Coming to primary resistance can be because of genomic features, transcriptomic signatures, and immune landscape. And acquired resistance with immunotherapy can be because of the loss of new antigen, deficiency in presentation of that new antigen, defect in T cells, and upregulation of alternative immune checkpoint receptors. We will see in next few slides. Coming in detail with tumor intrinsic mechanism of resistance to immunotherapy. So that can constitute lack of tumor immunogenicity. Lack of tumor immunogenicity means there is lack of new antigen, that is low tumor mutation burden, or that can have a tumor can have heterogeneous antigen. So it is difficult to target a single antigen. Mutation in various genes. Other intrinsic mechanism is deficiency in antigen presentation. It is important interferon gamma signaling pathway, we will see, and aberration in several signaling pathways such as MAP kinase, PI3K, WNT, and interferon pathways. This defect in these pathways can cause immunotherapy resistance. Coming to first, low tumor mutation burden or new antigen load. So this new antigen is because of non-synonymous mutations. And this non-synonymous mutations cause new antigen formation, and this new antigen formation is known for tumor mutation burden. So how tumor mutation burden is calculated? It is calculated as total number of non-synonymous mutation per DNA megabase. And if tumor is having low mutation burden or low new antigen load, then patient is not having that response to immunotherapy, and that leads to primary resistance. Another mechanism of intrinsic tumor resistance is increase in new antigen intra-tumor heterogeneity. Now we have different types of new antigen in the tumor. That is heterogeneity in new antigen, and that is defined as intra-tumor heterogeneity, relative fraction of subclonal. Now we have subclonals. Many clones of new antigens are now present in tumor, and that impairs sensitivity to immunotherapy. So combining that high tumor mutation burden along with low intratumoral heterogeneity, we can predict the benefit from immunotherapy. So when we see that patient is having high PD-L1 expression, patient also have EGFR, ALK, ROS, MET, or BRAF mutations. Because these patients have developed a defect in certain oncogenes, there is increase in function of some oncogenes or decrease in function of some tumor suppressor genes. So because of mutation in these driver genes, that impairs immunotherapy sensitivity. This is an important pathway. You can see here that when interferon gamma binds with this interferon receptor that activates JAK-STAT pathway, and via this pathway, they upregulates this MHC1. When MHC1 is upregulated, then antigen presentation is enhanced in tumor. So if there is defect in this interferon gamma signaling pathway, then there will be downregulation of MHC1, and it will cause again this primary resistant to immunotherapy. So interferon gamma is a cytokine that is secreted by T cell, NK T cell in the tumor microenvironment, increases antigen presentation by upregulation of MHC, and also it secretes CXCL9, CXCL10, CXCL11, which attracts the cytotoxic T cell in microenvironment. Another mechanism of this intrinsic mechanism of resistance is deficiency in antigen presentation. So we have seen the loss of neoantigen. Loss of neoantigen can occur because of pro-inflammatory cytokines such as TNF alpha, or that those tumor infiltrating lymphocytes secretes interleukin 6 or TGF beta, and these can lead to loss of neoantigen. Or these neoantigen, before getting presented to those antigen through that MHC1, they are processed by proteosomes, then they are transported via that endoplasmic reticulum, Golgi body, and then presented via this MHC1 to antigen presenting cells. So if there is defect in those transporters, then antigen presentation will not occur, and then it will lead to resistance. And we have already seen that defect in interferon gamma signaling pathway, it will lead to downregulation of MHC1 and further lead to neoantigen, this defect in neoantigen presentation. So we have seen the intrinsic mechanism of immunotherapy resistance. Second is host-related characteristics. So gut microbiota is a new thing which is coming, and it has been implicated in the cause of cancer, and has also been seen to modulate the treatment efficacy. So when there is alteration in the gut microbiota, that can alter the response with either chemotherapy or immunotherapy. So the study has shown that patient not having response with immunotherapy have shown to have increased levels of this bacteroideals, and responders have increased Faecalibacterium in their gut. Diet can also affect our immunotherapy response. Low liver arginine, tryptophan can decrease the response, while high lactate can increase the response. Steroid decrease our inflammatory cells, so it can cause resistance, while antibiotics can again alter this gut microbiota and can further affect the immunotherapy response. Inflammation state and autoimmunity are other reasons of host-related characteristics. So we have seen intrinsic mechanism, we have seen host-related mechanism. Now this is very important for theory examination, tumor extrinsic mechanism. So this is tumor microenvironment. Microenvironment means apart from tumor, there are several cells in the tumor niche, and those are the cytotoxic T cell, those are regulatory T cells, stromal T cells, these tumor-associated macrophages, dendritic cells, and they further secrete various cytokines, and there is a complex interaction between all these cells, and that can affect again the response with immunotherapy. So tumor extrinsic mechanism of resistance can be T cell related factors, that T cell if get exhausted, or there is a defective cytotoxic T cell, or there is change in T cell receptor, or there is a epigenetic modification in this T cell, then there will be lesser response with immunotherapy. Second is immunosuppressive cells. As I have told, there are several cells in this tumor microenvironment like Tregs, stromal cells, and tumor-associated macrophages. They secrete various cytokines. Suppressive cytokines, they further decrease the activity of these cytotoxic T cells. So what are tumor-infiltrating lymphocytes? In those this tumor microenvironment, we have various lymphocytes, the cytotoxic T cell, Reg cells, and dendritic cells. So tumor can be further classified depending upon this tumor infiltrating lymphocyte into hot, altered, and cold tumor. So if there is high number of tumor infiltrating lymphocyte, we call it as hot, and patient having less number of TILs, then we can it as cold or altered. So low TIL means more of immunotherapy resistance. Change in T cell receptor can further cause immune resistance. So apart from PD1, PDL1 interaction or CTLA4, B7 interaction, there is activation of other immune checkpoint receptors, and there is upregulation of other immune checkpoint receptors such as lymphocyte activation gene 3. So this is the most common gene which get activated in this checkpoint receptor upregulation, and these are several other genes which are responsible for this mechanism. Next is T cell exhaustion. Because of continuous cognate antigen triggers, this T cell get exhausted because of continuous presentation of antigen, and later it get permanently exhausted. And because of this exhaustion, then we can have this immunotherapy resistance. So as I have already shown that in tumor microenvironment, we can have suppressive cells such as regulatory T cells, myeloid-derived stromal cells, tumor-associated macrophages. They secretes various cytokines. They are suppressive to cytotoxic T cells, and these cytokines further recruits these regulatory T cells and stromal cell in tumor microenvironment. So further adds on resistance. What are the other immunoregulative molecules in tumor microenvironment? They are adenosine. They inhibit cytotoxic function of T cell. CD73 that cause T cell exhaustion. B7H4 that downregulates T cell function. So these are intrinsic, host-related, and tumor extrinsic mechanism of resistance. So how can we tackle this immunotherapy resistance? We all are doing in our day-to-day practice. With immunotherapy, we are adding chemotherapy. With immunotherapy, we are adding target therapy, like in pembrolizumab and chemotherapy in lung cancer. We are adding bevacizumab and atezo in lung cancer along with chemotherapy. We are adding lenvatinib in immunotherapy in RCC. So we can add a separate class of drug with immunotherapy to handle this resistance. Regarding lung, there are several trials going on. So chemotherapy is being tried along with immunotherapy. This is Poseidon trial with durvalumab. Radiation therapy along with immunotherapy. Two different kind of immunotherapy can be added, like pembrolizumab, nivolumab and ipilimumab. Already we have data in lung cancer. So two different kind of immune checkpoint inhibitors can be added. We can add co-stimulatory agonist along with immunotherapy. So data is coming, and target therapy along with immunotherapy, epigenetic modulators, oncolytic virus, cancer vaccines, and gut microbiome modulators. So these kind of things can be added along with immunotherapy to handle all these immunotherapy associated resistance. So this is my last slide. To conclude, we have seen that there are various mechanisms of resistance with immunotherapy, and they are very complex and dynamic, and we can't really clarify because these mechanisms are certainly overlap with each other. And we have seen that these primary and acquired resistance is very important for clinician to make a reasonable combination of treatment, that we should add chemotherapy or target therapy along with immunotherapy to handle all this resistance, to improve the survival and to avoid the additional toxicity to the patient. Thank you so much.